I'm delighted to introduce you to Dr. Jeffrey Weber, who is here to fill us in on the latest advances in immunotherapy for melanoma and other skin cancers. Dr. Weber is the Deputy Director of the Perlmutter Cancer Center and co-director of the Melanoma Research Program at NYU Langone Health, as well as the Laura and Isaac Perlmutter Professor of Oncology at the NYU Grossman School of Medicine in New York City. Don't forget that while Dr. Weber is speaking, you can put your questions for him in the Q&A box. Brian Brewer from the Cancer Research Institute will be sharing them with him as we go along. I'll now turn it over to Dr. Weber and Brian as we delve into immunotherapy for melanoma and other skin cancers.
Thank you very much for that kind introduction. What we have in front of us is a picture of a very nice lady with her children who a long time ago had metastatic melanoma. She was one of the first patients treated with the first checkpoint inhibitor that was approved, ipilimumab, had a complete response, and has been cancer-free for a long time. Now, frankly, that's not an unusual scenario. I have a bulletin board next to me that's filled with postcards and photographs of people that I treated anytime in the last 20 years. And my first patient treated with immunotherapy was indeed 20 years ago. And a lot of them are sending me postcards showing them playing golf, going on vacation. They're perfectly happy and healthy. They're all in complete remission, and they've all done very well, as this lady has. She's had 2 children, both alive and well. And 30 years ago, this would not have happened. So I think it's a very important thing that we now have truly effective drugs for melanoma. And checkpoint inhibitors really have changed the face of cancer therapy in general, not just in melanoma. So we're talking about melanoma, but we also need to talk about skin cancer because melanoma is only one type of skin cancer. We have basal cancer and squamous cancer, which begin in different types of cells within the skin. We have Kaposi sarcoma, which really was a relatively common skin malignancy in the HIV era, which has waned in numbers and significance since we now have effective antiretroviral therapy. And we have the relatively rare Merkel's cancer, which begins in a cell layer between the epidermis and the dermis, between the outer skin and the inner skin. And that's a scenario where you can also have very effective immunotherapy. But of course, the bad guy is melanoma. That's the skin cancer that can be lethal. And if you look at that right-hand panel below, you see the little blue cell with the little finger-like processes. That's the melanocyte. We all have them. They tend to be at the dermal epidermal junction between the inner and the outer skin, and they make pigment, they make melanin, which we need to protect us from UV light and the sun. And it's those cells that get transformed that cause a melanoma. And melanoma comes in different types, different stages, and we call it staging because it allows us to characterize where the melanoma is gone, where it's spread, which gives us outcome. It tells us the prognosis. The prognosis is simply a prediction of how well someone will do. You can have stage 1, 2, 3, or 4. If you look at the left-hand panel on this slide, stage 1 means you're just into the outer skin, the epidermis, or just through the epidermis, just abutting on the very top of the inner skin, the dermis. That epidermis is the dark pink, light pink is the dermis. Stage 2 is more advanced. Now, if you take a close look, you realize that brown, darkly pigmented tumor is invading past the epidermis into the dermis, and how deeply it goes tells you the stage. You can have stage 2A, 2B, or 2C. If you look at the lower part of the right-hand panel, a 2C lesion is ulcerated, which is that red part. It's eaten away the outer skin, and it's probably bled, and it's invaded all the way through the inner skin, the dermis, the light pink area, and it's into what we call the subcutaneous tissue, the support tissue, which is what we see in yellow. So no question, that is a very deeply invading cancer. But these are all melanomas that have stayed in the skin and haven't gone anywhere else. If you look at the next set of staging slides, you come to stage 3 and stage 4, which we'll bring up in a moment. Stage 3 is on the left. That means it's gone beyond the skin. It's past the outer skin, the epidermis, past the dermis, and it's now gone into the lymph nodes through the lymphatic vessels. And on the left, where it says stage 3, those little green things are the lymph nodes. And the tumor has expanded, in this case, out of the arm, and now it's into the lymph nodes that are either in the elbow or under the arm. And that's stage 3 disease, which carries a worse outcome, a worse prognosis. Stage 4, it's spread distantly. It could be the bone, the brain, the liver, it could be any other organ. And those are the patients now at risk to die from melanoma. On the other hand, patients used to have a very high risk of dying. Now they don't. Now, some patients will still die of melanoma, but we now have immune therapies for melanoma that are very effective. Aldesleukin was the first one approved, my God, 1998. That was a so-called interleukin-2, known as aldesleukin. But since then, we've had ipilimumab, which is the original checkpoint inhibitor. We had ipilimumab with nivolumab being the next generation. We had nivolumab, pembrolizumab, which are two PD-1 antibodies that work a little differently than ipilimumab, which hits a molecule called CTLA-4. And we have nivolumab in combination with another drug called relatlimab. We have tebentafusp, which is a very complicated little molecule that brings together immune cells and the cancer cells and gets the immune cells to kill them. That's used only in ocular melanoma, melanoma that begins in the eye, which is quite rare. And we have the old standby interferon, which we don't use much anymore. It doesn't work very well. And atezolizumab is another immune checkpoint inhibitor, but it's only approved with the so-called targeted therapies, the BRAF/MEK drugs. We call them vemurafenib and cobimetinib. And let's not forget about the targeted drugs. We do have 3 sets of targeted combination drugs that target the melanoma. They target a genetically altered molecule that's in melanoma, not in you, the patient, but only in the tumor. And they can do a very good job of targeting the melanoma and killing it. There are 3 doublets. We call them vemurafenib, cobimetinib, encorafenib, binimetinib, and dabrafenib, trametinib. And they work in combination better than either alone. And they work not quite as well as immunotherapy. So we always go with immunotherapy first, and we use the targeted therapies and keep them in our back pocket. We'll use them later. There's also a drug that's been repurposed called imatinib and another drug called nilotinib. Bizarrely, they're used in chronic leukemia, but they can target a rare mutation in the unusual melanoma that starts not in the skin, but in the mucous membranes, the nose, the mouth, vaginal area, the anorectal area, the urethra. Those are the rare mucosal melanomas, and they tend to have a genetic mutation called c-KIT, and they can be targeted by those 2 drugs that I mentioned. Let's go on to the next. Lastly, keep in mind, other skin cancers like basal cancer and squamous cancers have approved immunotherapies. We have a drug called cemiplimab for basal cancer and squamous cancer. We have pembrolizumab for squamous and Merkel's, and we have avelumab for Merkel's cancer. So for all the other skin cancers, we also have immune drugs that work, and we have these targeted drugs. In fact, the first drug ever approved for basal cancer was a targeted drug called vismodegib. And it was actually approved amazingly on the basis of one study of fewer than 100 patients led to its approval. That was an amazing study. And cetuximab is an antibody that's also approved for squamous cancer. So we have lots of drugs, but don't think that just because we have lots of drugs, no one ever dies of melanoma or other advanced skin cancers. It still happens.
Dr. Weber, thank you so much for that update on the latest in immunotherapy for skin cancers and melanoma. Sounds like a lot of exciting progress has happened in the past 20 years, and sounds like there's a lot of cause for optimism among patients who are facing these types of cancers today. We have an audience of patients and caregivers here with us who have been watching your presentation and are submitting questions through the Q&A box. So why don't we just go ahead and jump right in? First one is, I was getting a checkpoint inhibitor for melanoma. I had to stop treatment due to side effects, and I'm being switched to another treatment. Does this mean the immunotherapy isn't working? Or will my immune system keep fighting cancer after I stop it, even after the side effects have gone away?
Even after those side effects go away, it's felt that checkpoint inhibitors impact on the body's immune system and on the body in general for months. just the half-life of the antibody alone is 2 to 2.5 weeks. And you have to go through 5 or 6 half-lives. So you do the math, it's like 12 weeks to get it out of your body completely. That's just the antibody getting out of your body. The antibody's effects probably carry on for many months, literally, if not years. So I would say in someone who had to stop because of toxicity, which probably reflects a pretty significant impact on your immune system, by the way, the activity will continue for months and maybe even years. And continuing for months may be all that is needed to mediate or cause a positive effect to clear the tumor.
As a follow-up on that, why is that the case with other treatments when they stop, the treatment effect stops? But why is it different with these treatments, these immunotherapies?
Well, remember, immunotherapy is not your grandmother's chemotherapy. With chemotherapy, what you see is what you get. If you took a test tube and put in some tumor cells and you added the chemotherapy drugs, it would probably kill most of them. Some of them might survive, but most of them will die. If you took tumor cells in a test tube and you sprinkled in these immune drugs, nothing happens. But if I took your peripheral blood cells containing your immune cells, exposed them to these antibodies, these immune checkpoint inhibitors, and then added that to the tumor, it would kill the tumor. So it's an indirect effect. So, and that indirect effect may continue literally for months, if not years. It's the equivalent of getting, say, a vaccination. Let's say you get a hepatitis vaccine. I had a hepatitis vaccine 35 years ago. In my body, there are still antibodies directed against hepatitis B. I actually had one of the first recombinant vaccines back in, I don't know, my God, it was so long ago, I didn't remember. And that vaccination, that boosting of immunity has literally lasted for 35 years. So if that kind of vaccine can last for that long, the boosting of immunity with an immune checkpoint inhibitor would be not surprising that it would literally last for months to years. So I would be confident, especially in the face of having had these toxicities, an immune-related adverse event. There's a vague association in some tumors between getting the side effects and doing well, meaning having a long-lasting anti-tumor immune effect. So I'd ironically be a bit confident that whatever effect is there is going to continue. In addition, we've treated patients with one dose of immunotherapy, and they've then had side effects, had to stop, and they've had complete responses lasting a decade or more. So it's not the necessary number of doses, it's how it affects your immune system that counts.
That's fascinating. Actually, that's a great segue to another question we received from the audience. My aunt with stage 4 melanoma is just now starting treatment with immunotherapy. How will we know that it's working for her? Are there any kinds of signs that are common we can look for? And you just mentioned side effects might be one of those signs.
Side effects are a loose association. In melanoma, the most important side effect that's associated with outcome is vitiligo, which is loss of pigment. Now, if you're a moderately darkly complexioned person and you lose your pigment in patches, this is what vitiligo is. It's basically the melanocytes die and stop making pigment. So you have whitening of the skin in patches, not usually the whole skin, it's just in patches. And for a darker complexioned person, that might be upsetting or cosmetically displeasing. But when we see patients who come to the clinic and we look at their complexion and realize they're losing their pigment, we love it. We always say, oh, wow, that's vitiligo. We love vitiligo. And they may say, oh, it's gross. My complexion is all blotchy. And we reassure them and say, it's great. It is an immune reaction against your own melanocytes, which make the melanin, the pigment, and it reflects an ongoing immune reaction against melanoma. So if that happens, you're in good shape because those patients always do well. That's the one side effect that could predict outcome. Other side effects don't predict outcome very well, if at all. The only other way to decide if an immune treatment is working is if there is tumor that can be seen or felt on the skin or under the skin. If it's getting smaller, you're in good shape. If it's getting bigger, you got a problem. The other thing is, until week 8 or week 12, whenever the evaluation is by scans, you're not going to know. In the absence of measurable disease, meaning something you could feel on the skin or under the skin, you're not going to know if it's working until such time as you get scanned. So it's frustrating, but that first scan may be the first indication of whether it's working or not.
That's fascinating as well. With vitiligo, is this immunotherapy causing the immune system to attack healthy melanin cells as well as cancerous
Well,
melanin cells?
that's exactly correct. Melanocytes are our normal pigment expressing cells. They make melanin. The melanin protects us from the sun, from UV irradiation. And what we tell the patients is your body is now, the treatment is now attacking some normal cells in your body. Now, hopefully that's the only normal cell it's attacking. It's not anything else. But they've just lost their sun protection. And we always tell them, if you get vitiligo, then you need to put some serious sun protection, some SPF sunscreen on if you're ever out in the sun, because those people will burn in 5 minutes. Now, we've had patients with virtually total body vitiligo. Their hair will turn white, their lashes will turn white, their eyebrows will turn white. And I actually am thinking of a man who came in one day. He had sort of dark blonde, light brown hair. And he was in his 50s, going a little bit gray, but his lashes and brows were like brown. And he walked in, and his eyelashes were totally white. And I said, "Whoa, whoa, whoa! When did this happen?" And he said, "It's funny. My wife mentioned that this happened over the last couple of weeks." I said, "Really?" I said, "But what happened to your hair?" He said, "Well, that started to turn dark, but I dyed it because I couldn't see that his hair had changed." And I said, "I tell you what, the next time you come in 3 weeks, please take out the dye." He came back 3 weeks later. His hair was completely white, eyelashes totally white, eyebrows completely white, and he developed total body vitiligo. Amazing. Now, he was a pale guy to begin with, so it wasn't that dramatic, but wow, that's big time vitiligo. And of course, he's done very well.
Wow.
So that's the one thing that's going to tip you off. Otherwise, unless you can feel something, you're not going to know for another 8 to 12 weeks. The one weird thing is you can see pseudo progression with these drugs, meaning the tumor could become inflamed and the tumor could die, but it gets inflamed and it looks like it's getting bigger. And only with time do you realize it'll then subsequently shrink. So we have to be a little careful declaring when someone has progressed. We have to make sure it's not pseudo progression.
Right. Another question. My father received immunotherapy for melanoma, but it didn't work. Why does it help some patients but not others?
Well, I guess the flip answer to that is if I could give you an intelligent, comprehensive answer to that, I wouldn't be here. I would be sitting on a beach in Tahiti under an umbrella, sipping on a little Mai Tai with one of those little umbrellas in it, counting my money.
Wearing sunscreen and a hat, I hope.
Wearing SPF 50, my Tilly hat, and trunks that extended down to my knees. So, but that's why I said under an umbrella. Nobody can give you a really intelligent answer as to why some people do not respond and some people do. It is the holy grail of immunology and immunotherapy to understand what about the tumor and what about the body itself, the normal tissues, the immune cells, dictate that someone will respond to immunotherapy or not respond. We spend a huge amount of effort trying to understand this. We have a huge grant called a SPORE grant in melanoma to try to figure this out. We do know that there are certain qualities about the tumor that will bode ill if you don't have immune cells infiltrating the tumor, a so-called cold tumor, that bodes ill. If you do not have a molecule called PD-L1 on the tumor, that's something that the PD-1 antibody can prevent the PD-1 molecule from binding to. It's like a brake on the immune system. If there's a whole bunch of break, that's good because that's what you're going to break apart or disconnect. But if you don't have that molecule, it's a reflection of the fact that you have very little immune response in your tumor, and that bodes ill. If you have lots of genetic changes or mutations, we call this the mutational burden, that sets up targets for the immune system. If you have lots of those, that's good. If you don't, that's bad. The problem is even adding them together, all these tumor factors, only gets you a weak element of prediction. we have a factor which we call the area under the receiver operator characteristic curve, otherwise known as AUC. If the AUC is 0.5, that's like flipping a coin. If the AUC is 1, that means 100% predictive power. If the AUC is under 0.8, it stinks. For every test we have, the AUC is less than 0.8, which means they stink. If you have an AUC of above 0.8, you're looking good. If your AUC is above 0.9, you're in. Now, we're developing some factors that may have an AUC in the range of 0.9. We'll see whether that pans out. We're still working on it. But if you look in the blood of the patient, there are certain factors that are associated with a bad outcome. If you have lots of interleukin-6 and interleukin-8, bad news. If you make lots of gamma interferon, that's good news. If you have a certain type of immune cell, that's a suppressive cell, bad news. If you have a certain type of immune cell that is an activated cell that kills things, that's good news. Eventually, we're going to put them all together in some algorithm and hopefully be able to predict who's going to do well and who's not. On the other hand, let's say you're going to do badly with immunotherapy. Okay, then what do you do? If you're BRAF mutated, you'll get targeted therapy up front. But if you're not BRAF mutated, then what do you do? That's a tough question.
Hopefully the person's father who asked that question was able to get one of those additional treatments after and is faring well. But it's talking about all of these signals. We do have another question about genetic tests. So you're mentioning MEK and BRAF. So the question is, do I need to ask my oncologist to do genetic tests, or will she do it automatically? I'm in a rural area. Do I need to travel to a city to get these tests?
Well, I think that there's no harm in asking the oncologist whether they're going to do next generation sequencing or test for BRAF, B-R-A-F. Never hurts to ask. I would say that's an engaged patient, and no oncologist should ever resent that question. You don't have to be in the middle of a big city to get BRAF testing. It's usually something that's sent. A bit of tumor is sent to a central lab. So it doesn't matter where you are. You could be anywhere in the United States. You should be able to get BRAF testing done and next generation sequencing also. So those are critical things that should be done in any patient with stage 3 or stage 4 melanoma.
Why not the earlier stages?
Because it won't affect the management if you have stage 2 melanoma and you have a BRAF mutation. Who cares? If you have stage 3 melanoma and you have a BRAF mutation, that opens up a chance of getting adjuvant BRAF/MEK therapy. So you do a test if it affects the management. Don't do a test, which costs money. No need to waste money. Right. Don't do a test if it doesn't impact on how you'll handle the patient.
Because the earlier stages are treatable with surgery, I guess, right?
Early stages are treated with surgery alone, and there's now an approved immunotherapy for stage 2B and 2C melanoma that's been surgically removed. So those patients might be treated with immunotherapy, but it wouldn't matter if they're BRAF mutated or not.
All right. We talked about tests. Let's see. Oh, here's one. My husband's doctors tell him that a dermatologist should monitor the red patches on his scalp, actinic keratoses, as they say there's a risk it could progress to cancer. Will immunotherapy help him if it does?
Strangely, immunotherapy probably doesn't do much for actinic keratoses. I've certainly got some on my scalp. They either get treated with topical 5-FU or they get burned off or treated with liquid nitrogen. So I see the dermatologist twice a year. Any melanoma patients should see the dermatologist at least that often. And I always get something biopsied or burnt off. But no, there's no reason to think that immunotherapy will help. Interestingly, if the actinic keratoses degenerated and became a squamous invasive cancer, that's when immunotherapy might be used.
Let's see. Another question, and this is a question we often get here in our summits around cost. This one is asking, will insurance cover my immunotherapy treatment? I have stage 3 BRAF positive melanoma. Is immunotherapy a standard treatment for that?
Absolutely. Ipilimumab, nivolumab, pembrolizumab, ipi-nivo, the combination, nivo or relatlimab, those are all FDA-approved treatments for metastatic melanoma. Insurance has to cover them. They're not investigational. They're standard of care, FDA-approved therapies. We've never had a problem with insurance coverage for those drugs in metastatic melanoma.
That's great to hear. Next question then, why don't we move on? Is melanoma hereditary like some other cancers are? My mom had a scare a while back, but a simple surgery removed the worrisome moles. Now I'm very worried about myself and my children.
Well, melanoma is only hereditary in the rare case of patients who have familial atypical nevi. And that's a syndrome where people have a lot, and I mean a lot, of funny looking freckles. You know, when you see somebody like that at the beach back in the old days, you would look at them and say, whoa, that is a patient that definitely has familial atypical nevi. And that's someone who definitely should see the dermatologist every 3 months. Those patients will almost always develop melanoma by the time they're 40. They should stay the heck out of the sun. And they have a mutation called P16, which causes the melanocytic proliferations, the growth of the pigmented precancerous lesions, which degenerate inevitably into melanoma. Other than that, which is maybe a few percent of all melanomas and is rare in the population, you will find that melanoma is not directly genetic. Now, in a sense, it is, because people who develop melanomas tend to have blonde hair, red hair, lots of freckles, blue eyes, green eyes. So I suppose in that sense, your hair color, your eye color is inherited, right? It's inherited in the germline. But that just describes the risk group. So in that sense, if your mom and dad both had blue eyes and blonde hair and lots of freckles, yeah, you're probably going to inherit pale skin, lots of freckles, and blonde hair and blue eyes. But that puts them at the risk in a risk group, and it puts you in a risk group. So in that sense, it's inherited, but that's an indirect inheritance.
I see. So are people who have darker skin tones less at risk, or are they not at risk at all of developing melanoma?
Well, I would never say someone's not at risk for developing melanoma. Those who are darkly pigmented are at a very low risk of melanoma. The lowest recorded risk of melanoma, interestingly, is in Bombay. People in southern India are very darkly complexioned, and they just don't get melanoma, even though they're out in the sun and they're not that far from the equator. People who live in Iceland don't have a very high risk. They're very pale, they're very blonde, they have very blue eyes, but there's no sun in Iceland. So unless they go to Ibiza in Spain and bake in the sun for 3 weeks during vacation and get a horrendous sunburn, they're okay. So it all depends on where you live, what your sun exposure is, and what your complexion is. Those are kind of the determining factors.
I see. This is another person asked this question that's relevant. Is skin cancer or melanoma always caused by too much sun?
Not always. There are rare melanomas, maybe 1 to 2% at max of all melanomas, that begin in the eye, in the what's called their uveal melanomas, in the structure of the eye, not necessarily in the retina, but around the support structure of the retina. And obviously, that's not directly exposed to the sun. You also can have about 1% of all melanomas be in the mucous membranes, the nose, the pharynx, the throat, the urethra, the vaginal area, the anorectal area. I would hope those areas don't see the sun in virtually all people. And yet you can develop melanomas, but they behave differently. And they don't have the same mutational pattern. The pattern of genetic changes or mutations in skin melanoma always has the same signature. It's called a C to T transition, which is typical for UV light impacting on the DNA sequence. So that's how you know that skin melanomas are inevitably caused by sun exposure, or UV, to be exact, UV exposure. You look at a mucous membrane melanoma or a uveal melanoma, they don't have the same mutational pattern. In fact, they have very few mutations. The biggest number of mutations in cancer is in melanoma and squamous cancer of the skin. Why? Guess what? Both of them are associated with UV light exposure. What does UV light do to the skin? It causes a hell of a lot of mutations. The scary thing is to look at the number of mutations in ostensibly normal skin cells in a patient who's seen a lot of sun. There are hundreds of mutations in every cell. It is scary. But then those are the ones who develop melanomas, and those are the ones who develop squamous and basal cancers.
You mentioned at one of the markers is tumor mutational burden. It sounds like if you have a lot of mutations, that might be a good thing when it comes to immunotherapy.
Perversely, once you get melanoma, having a high tumor mutational burden bodes well for getting treated with immunotherapy. It sets you up to develop the disease, but once you get it, if you give the right drug, mainly the immunotherapy, you're probably going to do well. So yes, there is an irony there.
Also, a bit of a mixed message, I think, for people who are being told stay out of the sun. But I guess the bottom line is you don't want cancer anyway, no matter what.
Trust me, you want to stay out of the sun. You don't want to bake your skin. You don't want to go to the dermatologist every 3 months. You don't want to have basal cancers, squamous cancers, and melanomas. You just don't want to bother. Stay out of it.
That sounds wise. So we're just about out of time, but before we wrap up, we would like to ask you, how has the advent of immunotherapy shaped the way you treat cancer, as well as your expectations of patient survival?
Well, now we get disappointed if someone's not alive years later. And perversely, it had this bizarre effect where in a medical oncology unit, they would project the need for faculty time by the type of patient you would treat. And if you're treating melanoma, since patients did not live a long time, you needed a certain number of faculty per number of patients. Since now the patients are surviving long term and living a long time, you need more faculty. So there are more patients, which is great. But perversely, it increases or it changes the faculty workload assessment when you're looking at that cancer. And it's true for cancers across the board. The more successful we are, the more docs you need to take care of them, which is okay with me. But certainly the way it's changed things overall is great for patients. It is so gratifying to see someone who's sick as hell, who can't go to work, who looks miserable, is in pain. You treat them with immunotherapy drugs. 3 weeks later, they're a little better. 3 weeks after that, they're significantly better. At week 12, they have a gratifying set of scans. They look better, they feel better, they want to go back to work. And the most gratifying thing for me is to take somebody who's sick and put them back into the workforce and back into their normal type of lifestyle that they're used to. And I think that's what makes it all worthwhile. And you do that much more today than we did 30 years ago. And it's great. But trust me, unlike my boss, who thinks that we've licked melanoma and it's no longer a problem, that's ridiculous. Half of all patients treated with the most aggressive therapies for metastatic disease are still going to die of melanoma. We've got a long way to go. We've come a long way. And I'll tell you this, best is yet to come, as that famous philosopher, Frank Sinatra, always used to say.
Wow. Well, that's wonderful news. Certainly prospects are looking up for melanoma and skin cancer patients thanks to immunotherapy. Yes, there is a lot more to do, and we're so grateful that we have folks like you working on the front lines of immunotherapy for these and other types of cancers. So, Dr. Weber, I'd like to thank you for taking time to spend with us and all of our cancer patients and caregivers who are watching this program. I'd also like to thank NYU Langone, the Perlmutter Cancer Center there, for being a host organization for this program. We thank you very much, NYU, for your generosity in that as well. And to all of our audience members, thank you for sharing your questions with us. I'm sorry that we couldn't get to all of them, but I hope that you take away the wonderful news that Dr. Weber shared with us, and that you now are armed to speak with your oncologists about genetic tests, about immunotherapy, and clinical trials as well in your care or the care of a loved one. And with that, I'd like to say thank you, Dr. Weber, again, and thank you all.
Thank you.